So hi everyone, today we'll be discussing about radiological imaging in surgery. So this is a topic which I believe most of you ignore and don't go through in detail about it in your study during your preparation. So this is a chapter given in your Bailey and Love, and I believe directly or indirectly you get at least 3 to 4 questions from it in your NEET SS and INA examination. Okay, so I want to focus that this is a very important chapter and you need to go through it. Okay, so as in this era the imaging has become very important, and now there is a concept of known as image guided surgery. And because as a surgeon we are interested in anatomical and pathological imaging of the condition of the patient so that we can plan surgical procedures as accordingly. Okay, so moving ahead, so we'll be starting with the radiological imaging. So radiological imaging is nothing but it includes x-rays and various other ionizing radiation. So as from this image you will be able to understand what is the location of different spectrum of radiations which we commonly encounter in our daily life. So it starts from the infrared and goes up to the gamma rays, and as we move towards the gamma rays the frequency decreases and the power of ionization increases. So this is the thing which we need to understand. The next thing you need to know is the LRA principle. So LRA stands for as low as reasonably achievable. Okay, so here we want to keep the radiation doses to as minimum as possible, because there are harmful effects related to this ionizing radiation. So what are these effects? So these effects are hereditary effects, or the effects which can occur in a pregnant female, and these effects are on the fetus. So hereditary effects are nothing but the germline mutation, and it can occur in the male gonads or the female gonads. Okay, so here basically I want to stress upon that in a male patient, the X-ray pelvis and eye view, these are the two investigation which causes maximum exposure and maximum risk of hereditary effect on the paternal sides, and this should be judiciously used. The next thing we want to know is in a female patient, the hereditary effect leading to germline mutation is most importantly seen in if you get a barium enema done. So this difference is in the male and female patient is basically due to the location of the testis and ovary, and due to which different investigation impart different impact on this gonadal organs. Okay, so the next thing we want to see is the effect on the fetus. So this is an effect which translates when a pregnant female is exposed to such ionizing radiation. So in this case also the maximum effect is through the barium enema. So though we commonly practice that no X-ray or CT scan should be done in a pregnant female, but the maximum effect leading to childhood cancer and mental retardation is with barium enema. So these are the examinations and these are the effective dose equivalents. So basically what we want to know is that the myocardial perfusion imaging and the CT chest for pulmonary embolus is the two investigation which leads to maximum exposure or the dose of the ionizing radiation to the patient. So these two investigations should be used judiciously in any patient, and because there are radiation hazard with this investigation. So what are the hazards of the ionizing radiation? So there are two types of hazards, the predictable or all or nothing. So the predictable is dose dependent effect. So the more dose you give, those such effects would be more pronounced or more evident. So the example of a predictable hazard of ionizing radiation or dose dependent effect of ionizing radiation is cataract, and the other effect is all or nothing effect. It is basically due to the mutation in the gene, and it is dose independent, and that is why it is known as stochastic. So stochastic effect of ionizing radiation, the example is development of radiation induced cancers. Okay, so you need to learn this term, that is stochastic. So stochastic hazard of ionizing radiation is the development of cancer due to exposure of ionizing radiation. So whenever you advise for a investigation or a radiological imaging, you need to be very you need to behave very responsibly, because you cannot be non-judicious in advising such investigation, because they are associated hazard with it. So radiologists have a legal responsibility to keep imaging as safe as possible. The referrer or you has a duty to balance risk against benefit, and the referrer must provide adequate clinical details to allow justification of the examination. Avoid using portable mobile x-ray machines whenever practical, and take all precautions when using an image intensifier. The gonads, eyes and thyroids are especially vulnerable to radiation and should be protected. So this is the thing you need to be advising you need to be careful while advising such radiological imaging procedures. So you must have seen this circular symbols whenever you are visiting radiology department. So this is known as a band classification, and it depicts what is the lifetime additional risk of cancer induction per examination. So as you can see, there is no additional risk with ultrasound and MRI. If there is a one symbol, the typical effective dose you are exposed to is less than 1 millisieverts, and usually it is seen in chest x-ray of limbs, pelvis, lumbar spine and mammography, and the lifetime additional risk is less than 1:20,000. If you have two circles, the typical effective dose is 1:5, and it is usually seen in IVU, nuclear medicine investigation like bone scan and CT head and neck, and the lifetime additional risk is 1:20,000 to 1:4,000. And the third if you have three circular symbols, the typical effective dose is 5.1 to 10, and it is basically seen in CT/QB and nuclear medicine investigations like cardiac scan, and the lifetime additional risk of cancer reduction is 1:4,000 is to 1:2,000. And finally, if you are having four symbols, the typical effective dose is more than 10 millisieverts, and it is basically seen in extensive CT studies or nuclear medicine studies like PET scan, and the lifetime additional risk of cancer is 1:2,000. Okay, so this is the band classification which you must be aware of. So there is a criteria for useful investigation. So whenever you advise the investigation, that is a radiological investigation to a patient, you need to answer this questions to you. So this is the question you must ask to yourself. So has it been done already? Is it needed? Is it needed now? Is this the best investigation? Has the problem been properly explained? Okay, so this 5 questions decide whether you are being judicious or rational in usage of this radiological imaging methods. Okay, so this is the thing you need to follow. So the next thing is whenever you get a radiograph in your hand to examine, you need to check. There is a simple system for checking radiographs. So you need to go systematically. Is starting from label of the radiograph. So label, you need to check the name of the patient. Then you go ahead with site and date of examination. Then you look for the site, or you look for the check marker. So then you need to look for what part is the film centered on. Does the film cover the whole area covered? Is there more than one view? This all things you are assured. Then you need to assess the quality of the radiograph you are holding. So is the penetration appropriate? Now you need to compare how have the appearances changed from previous images, and then they conclude, is the diagnosis clear or is the further imaging needed? So this is the way you approach radiograph whenever you get a radiograph to assess. So starting with the chest x-ray. So in a chest x-ray, the points you should be looking for is the view. So first thing you need to assess what view you are looking into. So the next thing is the film under penetrated. So if the film is under penetrated, the thoracic vertebrae will not be seen. Okay, so does the thoracic spine align in the center of the sternum between the clavicles? This is the third thing you need to answer. Then you need to look for the levels of the clavicle on the both sides. Then the gastric bubble should be on the left. Check for the costophrenic angle, it must be sharp. Check the lung fields for the infiltrate, masses and margins, and increased interstitial markings or air bronchograms. Okay, so this is how your a complete assessment of a chest x-ray gets over. So this all points needs to be answered before you utter a word about the assessment of the chest x-ray. So there are two views which are associated with the chest x-ray. So what we commonly use is the PA view, and the next is the AP view. So this views are decided with the direction of the x-ray source to the film. So what is the direction the x-ray travels from the source to reaching on the film is depending on that, we call it either as a PA view, that is the posterior anterior view, or the AP view, that is the anterior posterior view. So there are different characteristics of both this view. So in the AP view, the heart appears magnified. In the PA view, the effect of heart is negated, and the scapulae overlaps lung in the AP view, and it is laterally posed in PA view, and the clavicle appears higher and ribs more horizontal in AP view, and the posterior ribs appears more magnified than the anterior ribs in a PA view. So this all we need to consider before coming to the conclusion while assessing a chest x-ray film. So coming to the examples of few of the X-ray films we'll be discussing. So starting with pneumothorax. So in this image you will be looking at the boundary of the left lung, that is the lateral border of the collapsed lung on the left hand side. It is marked by the arrow, and the rest of the pleural field is doesn't have any vascular markings or air bronchograms. Okay, so this is classical of a left-sided large pneumothorax. Okay. So here, this is a X-ray which can be considered as a X-ray of failure. Okay, so this is a X-ray denoting tension pneumothorax. So what is expected from you is you are expected to diagnose tension pneumothorax clinically, and if you are diagnosing it through chest X-ray, it is not a great sign about your skill. In this you can see the whole of the right pleural field is lucent, and there is no vascular or pleural markings. Okay, so this is classical of tension pneumothorax. So in this X-ray again you will be seeing there is an arrow, and the arrow depicts the visceral pleural line, and it is separated from the chest wall by a transradiant area lacking in vascular markings, indicating a right pneumothorax. Okay, so hope you are clear about this X-rays. These are very common X-rays. Again, this is a left-sided pneumothorax. In this, again, you are able to see the arrows causing mild mediastinal shift. There's a shift to the right. So this is a pneumothorax which is associated with the mediastinal shift. So again, so we are done with the pneumothorax. Now we should look to the other chest trauma findings. So here you can see that there is a opaque area on the lateral side of the left pleural field. So what happens is, when a chest trauma patient develops a hemothorax, in the supine position the blood tracks along the entire posterior section of the chest and is most notable pushing the lung away from the chest wall. Okay, so this is the way a hemothorax looks like on a supine chest X-ray. Same patient when got if a patient having hemothorax develops gets a upright chest X-ray, you will find this findings like this. Okay, so in the upright position the blood is visible dependently in the right pleural space. Okay, so there is blunting of the costophrenic angle, and whole of the lung shadow is at the apex area. So there is a next entity known as pulmonary contusion. So here you can see how the pulmonary contusion progresses from the initial X-ray at the time of admission and after 12 hours. So what I want to force upon is in a pulmonary contusion patient, the chest X-ray is not a great modality, because in the early phases it won't be able to detect. Okay, so to know about the full extent of the pulmonary contusion, you need to get a CT done, and it should be done as soon as possible. Okay, so this is the findings in a patient of pulmonary contusion. So next thing, so after lung we have a lot of vascular structure also in our thorax. So if a patient develops the traumatic aortic disruption, we will see such findings. So here you can see there is a widened mediastinum, and there is a depression of the left main bronchus. Okay, so this are classical findings of aortic disruption. So what happens now, though they were initially very much popular, but with the advent of contrast enhanced CT, we don't see such findings commonly in our practice. We get a CT done straight away if we are suspecting such type of grievous injuries. So again, we want to stress upon that just widened mediastinum does not mean there is a vascular injury. So here you can see there is a large mediastinal shadow, and it is due to large fluid-filled esophagus, which is seen in eclasia cardia, later stages, where we call it as sigmoidization of esophagus or sigmoid esophagus. The esophagus becomes so large that it is accommodating huge amount of fluid in it, and it is imparting shadow on the chest X-ray. So as we discussed about few of the traumatic vascular injuries in the thorax, there are different type of vascular injuries, and the location of hematoma within the mediastinal cell suggests the type of great vessel injury. Okay, so in the first X-ray you can see there is a predominant hematoma on the left, suggests the far more common descending torn aorta. Okay, so here you can see the mediastinal cell are parallel to each other, and they are almost parallel to the spine on the left hand side, and this depicts descending aortal tear. In the next most commonly injured vessel is the innominate artery. Here you can see there is a hematoma on the right, which indicates a relatively unusual but life-threatening innominate artery injury. Okay, so this is the finding of great vessel injury in the thorax. So though you can see the widening of the mediastinum associated with the descending torn aorta, but other findings which are also seen in descending torn aorta is apical capping and the tracheal shift. Okay, so this all are if present in a patient, this all indicates that you are dealing with a torn aorta. So coming to the next, that is the diaphragmatic injury. So in a traumatic diaphragmatic injury, you can see on the left-sided diaphragmatic injury, so it is more commonly on the left-hand side. It is because the lever is a natural protection for the right diaphragm. So here what we see is the gas-filled stomach is present in the chest, and because of herniation through a large diaphragmatic laceration. The same way you can see the gastric bubble is present on the plain radiograph showing the fundus stomach in the chest. So these are the features of traumatic diaphragmatic injury. So we are done with the chest X-ray. Now we'll be dealing with the abdominal X-rays. So if you get a patient of abdominal X-ray, you need to look for amount and distribution of gas within the bowel. What is the if there is any bowel dilatation present, and if there is any evidence of extraluminal air, if the soft tissue outlines of psoas muscle and kidney present, and what is the size and the shape of kidney, which is very difficult to assess on a abdominal X-ray, and apparent bony lesions or abnormal classification. So this three questions, when you ask and you are pretty sure about them, then only you have convincingly assessed the abdominal X-rays. So the most common pathology for which abdominal X-ray is done is intestinal obstruction. So first you need to understand what is the shadowing of a small and large intestine on abdominal X-ray. So the small intestine is located centrally while the large intestine is peripheral. So this is known as a picture frame of large bowel and the picture of small bowel within the frame. So this is how it has been historically described. And the next thing is you need to assess the diameter. Okay, so the diameter of the small bowel is usually less than equal to 3 centimeter, and it is usually less than equal to 5 centimeter for the large intestine, and for the cecum it is usually less than equal to 9 centimeter. So next, coming to the mucosal folds. So the small intestine have a mucosal folds known as volvuli conniventis, and it traverses the full width of the bowel, while the mucosal folds in the large intestine is known as hostration, and it crosses only part of the bowel wall. So this is a very differentiating feature while you assess X-ray, in which you are not able to assess whether it's a small bowel or large bowel. So coming to the next thing which you need to differentiate is whether there is a mechanical large bowel obstruction or the paralytic ileus. Okay, so small bowel obstructions are not as difficult to diagnose, but if you get a patient of distal mechanical large bowel obstruction and paralytic ileus, it looks almost similar on abdominal chest X-ray. So there is no cutoff point in paralytic ileus. Okay, so the concept of proximal dilatation and distal proximal dilatation and absence of distal dilatation is only for the mechanical large bowel obstruction and not paralytic ileus. So the next thing is presence of air fluid levels. So the air fluid levels is present only in the large intestine if the ileocecal valve is competent, and but in the paralytic ileus, if it would be present in both in small and large bowel. So considering the air fluid levels, so we need to be careful about the artifacts, the presence of artifacts in the abdominal X-rays. So you need to understand that the direction of the X-ray film and the X-ray plate. Okay, so it should be almost, the axis should be perpendicular to the axis of the air fluid level. Then only you will have film appearance of air fluid levels if they are present. So if the direction of the X-ray beam and the axis of the air fluid level coincides, then there will be no air fluid level seen on the X-ray film. So this is the basic thing you need to understand. So starting with the chest X-ray, we are now moving ahead with the abdominal X-rays. So the first abdominal X-ray I want you to look upon is a patient with sigmoid adenocarcinoma. So here you can see that there is presence of hostal markings. Okay, so here you can see the hostal markings are incomplete. They are not traversing the whole of the bowel circumference, and this is classical of large bowel. So we know that this is a dilated transverse colon that can be distinguished from the small intestine. Okay, so this is how a patient of obstructing sigmoid adenocarcinoma on abdominal X-ray looks like. So there's a entity known as Ogilvy syndrome or pseudo obstruction. So in a pseudo obstruction, the supine X-ray shows dilated large and small bowel loops, and you can see the enormous distension of the cecum. So much distension is prone to perforation. So you need to be very careful about the management of this patient because there is so much of distension. So finally, after the large bowel, we will move to the small bowel. So here you can see, so here this is the abdominal X-ray in supine position. So in supine position, what you see is just the gas-filled small bowel loops. So through this image, I wanted to stress upon why air fluid levels are not seen on supine x-ray and but seen on erect x-ray. Okay, so this was the basis, and now you can you can appreciate it that there is just air fluid, there is just gas filled small ball loops and not the air fluid. There are no air fluid level. The same patient when got erect x-ray, we can see the step ladder pattern, and we found out to have this patient to have ileal obstruction by adhesions. So this is how the positioning of the patient makes easier for us to diagnose such conditions. So again, we can see the supine abdominal X-ray showing multiple dilated gas filled loops of a small ball. Okay, so this is not classical. It is just the gaseous distension. And here you can see the patient is having multiple air fluid levels, and this is classical of small ball obstruction. Here you can again see there is dilated loops of a small ball in an orderly arrangement without evidence of colonic gas. So this can be this is a supine film, and through this there should not be any adhesion on the management of the patient. So the next day, the same patient when got upright film, the multiple short air fluid levels arranged in a stepwise pattern was seen, and this was diagnosed to have a small ball obstruction. So again, we can see there is a large radioepic gallstone present on the right hand side, and this condition is known as gallstone ileus, and the patient is having complete bowel obstruction caused by the large radioepic gallstones obstructing the distal ileum. Again, this is the upright abdominal radiograph in a patient with a sigmoid colon volvulus. So here you can note the characteristic appearance of a bent inner tube with its apex in the right upper quadrant. Okay, so this is how the sigmoid colon volvulus looks like, and this is known as coffee bean appearance. Here you can see again a patient of sigmoid volvulus. There is a bent inner tube appearance, and this is known as Freeman-Dal sign. So coffee bean sign and the Freeman-Dal sign are the two signs associated with the sigmoid volvulus. The next thing is the supine X-ray showing large gas filled viscous in the center of the abdomen. Okay, so you can see I would be marking with it. So this is the large gas filled structure in the center of the abdomen, and this is the classical feature of cecal volvulus. Okay, so this is how the cecal volvulus looks like. So after you have assessed the X-ray, you need to know that what are the bases to look for abnormal extraluminal gas. So the abnormal extraluminal gas can be present in the diaphragm, in the biliary system, or the portal vein, or within the bowel wall. Okay, so this all are the places you need to be looking for the abnormal extraluminal gas. So the intraluminal gas is not pathological in most of the patients, but abnormal extraluminal gas is pathological. So here you can see how the gas is lining the bowel wall both from the inner and outer sides, and this is known as Rickler sign. Okay, so here you can see the arrow is marking how beautifully the air is working as a contrast and imparting a shadow on the bowel wall circumference. So here you can see the gas is present in the gallbladder and the gallbladder wall, and this is known as emphysematous cholecystitis, which is due to the Clostridium perfringens infection, and emergency surgery is indicated in these patients. So again, you can see the plain abdominal radiograph demonstrating an abnormal collection of air in the right upper quadrant, consistent with the pyogenic hepatic abscess. So you are pretty sure now that there is anaerobic growth in this abscess, and you need to treat accordingly. So after we have read about the after we have read about the abdominal x-rays, plain abdominal x-rays, we need to understand about the barium images also. So there are two types of barium images. One is the single contrast and next is the double contrast. Okay, so the first thing I want to stress upon is the effect of compression for a single contrast barium image. So here in the first image you can see that if the patient is having any polyp or any ulceration, and we just ask the patient to ingest the barium dye and get a x-ray done, we will find that it is falsely negative. So after we are using abdominal compression, we are able to depict any filling defect or protrusions in the bowel lumen, and that can be seen on the barium images. So the effect of compression is very important for the single contrast barium images. So here we'll start with the claw sign of the iliac intussusception. So here this is a single contrast barium enema. So here you can see the barium in the intussusception is seen as a claw around a negative shadow of the intussusception. Okay, so this is the claw which we are talking about, and there is negative shadow here. Okay, so this is how ilio-ilial intussusception looks like. So the next thing is a barium enema demonstrating strictures in the transverse colon of patient with ulcerative colitis of 15 years duration. Okay, so here you can see there is a stricture here, there is stricture here, again there is a stricture here. So this all is a classical of ulcerative colitis, and this is a single contrast barium enema images. So again we can see this is known as Crohn's colitis, and the first thing you need to understand, there is sparing of the rectum. Okay, the rectum is spared, and this is a clinical finding which is useful in distinguishing Crohn's colitis from ulcerative colitis. Okay, so the barium enema radiograph demonstrates segmental involvement inflammation of the left colon. Okay, so here you can see there is a segmental involvement. So this segment is involved, then this segment is normal, then this segment is again involved. So this is classical and characteristics of Crohn's disease. So moving ahead with this image to the double contrast barium images. So in the double contrast images, what happens is we are using barium and air both to further increase the resolution of the image. Okay, so as we have seen in the Rickler sign, that air is also can also works as a contrast. So the same principle has been employed here to for the creation of a better image in a double contrast barium images. So this is a double contrast barium enema, and here you can see there are no hostrations. So as we discussed in our intestinal obstruction x-rays, that we need to look for hostrations to call it as large bowel, but here you can see there are no hostrations, and there is fine granular background, and this is typical appearance of ulcerative colitis. And the next thing you need to note is the gaping of the ileocecal wall, and this is also classical of ulcerative colitis. So this is again double contrast barium enema demonstrating typical appearance of the Crohn's disease with discrete asymmetrical ulceration and scapulation. So here you saw how segmental involvement is seen on a single contrast barium enema, and how it looks on a double contrast barium enema. So this is the difference, and this increases the resolution with double contrast barium enema. This feature, this image is just to stress upon the importance of double contrast. So when you are uh, uh, so in order to detect uh, uh, a growth or any proliferative lesion in the sigmoid colon, if you have not given a double contrast image, it would have superimposed and it would have appeared normal. But here you can see, you can detect it very evidently on a double contrast barium minima. So, though the barium contrast radiological imaging has gone down low with the advent of the endoscopy, that is the upper GI endoscopy, and the colonoscopy, but still for the small bowel luminal pathologies, the barium follow through is still very commonly used. So for the safety wise, since it is a non-interventional thing, so the safety of the barium contrast is higher, but the diagnostic accuracy is slightly higher for the endoscopy. The detection of the superficial mucosal lesions is better in the endoscopy, and the detection and management of bleeding lesions is also better in the endoscopy. You can, because it can be therapeutic also. And the biopsy is not possible in barium contrast, but usually possible in with endoscopy. The ionizing radiation is used with the barium contrast, but it is not present in endoscopy. The hot copy is automatic, but it is not present in endoscopy in most of the cases. And if there is subtle stricture, it is better evident on a barium study than an endoscopy. And overall topography and surgical mapping is better for this barium contrast, and it is poorer in endoscopy. And the study of the distal duodenum and the small bowel, where endoscopy is not routinely possible and easy, it is a prime method to the barium is the prime method to study distal duodenum and small bowel. So as we know, we are very much fond of contrast, but I want to stress upon that in certain situation that contrast imaging is not is more it produces more confusion than the non-contrast images. So here you can see that in a patient of stag on colculi, if you get IVU done without a plain X-ray, you will see that the stag and colculi has been evidently masked by the contrast, and you find it a normal study. So that is why in a plain X-ray is always important before considering a contrast imaging. So as we discussed at the time of X-ray, that is the chest X-ray, that is the PA view and AP view. This is the basic principle for all the lesions which you encounter in radiological imaging in chest X-ray, which is a 2D study. Okay, so here you can see that is if the mass is in the lower lobe, it can be the shadow of the mass and the shadow of the heart is very much different from each other, and you can delineate the mass on the lower lobe without any confusion. But if the same mass is present on the middle lobe of the lung, the shadow of the mass and the delineation is very difficult, and that is why the 3D positioning of the lesion makes it difficult for the lesion to be identified with the adjoining eye organs. So this is the basic demerit of X-ray study, and this led to advent of the CT scans. Okay, so before we move to the CT scans, we need to know that since in CT scan, most of the CT scans used now is the contrast enhanced CT scan. So what was the history, and through what phases the contrast has been developed developed, and how we should be careful about their usage. So initially we were using conventional contrast, and it were salts of triiodinated benzoate anion, and the example of which was sodium and meglumine iothiolate and metrizoate. Okay, so the problems associated with was nausea and vomiting, endothelial and red cell damage, vasodilatation, and these conventional agents are now hardly ever used for intravascular studies. Okay, so the next thing is next class was ionic low osmolar and mono and diamer compounds that can package the same amount of iodine and half the osmolarity was used, and the examples were sodium and meglumine ioxalate, and they had much reduced osmolar effects, have a reduced incidence of urticaria and hypotension, and following which there further improvement in the contrast, and now the non-ionic low osmolar agents are used, which are produced by the replacement of the carboxyl group by a non-ionizing radical, an example of which are iopamidol, iohexol, iopromide, and the problems with are relatively small. So the bronchospasm, urticaria, mild hypotension is very low, and the life-threatening reactions are even lower than the compared with conventional agents. So what are the relative contraindication to the intravascular contrast media? Okay, so the conditions like sickle cell anemia, if you give contrast, it can lead to sludging and thrombosis. In a pheochromocytoma patient, the paroxysmal hypertension can produce. In a myeloma patient, can be renal tubular blockage, and in asthma patient can be induction of the bronchospasm, and in renal failure patient there can be exacerbation of the renal failure, and finally if there is history of idiosyncratic reaction, the further reaction can be produced by the injection of the contrast media. So now coming to the CT scan. So this is how the basic CT scan machine looks like. So we have X-ray source on one side, the patient, and then we have detectors which are revolving with the X-ray source along the longitudinal axis of the patient, and this is how we digitally reconstruct the images in various sections of human body. So this is how the basic CT scan looks like. So we have the source, we have the detectors, and it is revolving in a helical pattern along the longitudinal axis of the patient. So initially we had single dimension CT scans. Okay, so it was very difficult to reconstruct the images, and the patient you needed to withhold breath for a very long time. Now we have MDCT, that is the multi-dimensional CT, and because both the detector and the X-ray source and the patient, all the three things are moving along, then we get multi-dimensional CT images, and the reconstruction is very easier with them. So the whole basis of CT imaging is the concept of Hounsfield units. Okay, so we have imparted air as a Hounsfield unit of -1000, the water as 0, and the bone, that is the trabecular bone, around 500 to 1000. So this is the range of Hounsfield units. Now coming to the lungs, the Hounsfield unit is around 900 to 300. The fat is having -120 to -80, and the muscle is having 10 to 30, soft tissue 10 to 30, and the cortical bone 50 to 100. So this all leads to identification of structure which are present adjoining to the pathology, and this all can lead to better reporting. So this is how the X-ray source, detector, and the patient moves along the three dimensions, and this leads to creation of wonderful reconstructive images. So what are the strength of CT? So it has a high spatial and contrast resolution. The contrast resolution is enhanced by ability to image in multiple phases, including arterial, venous, and delayed phase. Okay, there is rapid acquisition of image in one breath for hold. The imaging of choice for the detection of pulmonary masses, and it is very difficult with the X-rays. As we discussed, there is a problem with the artifact. Okay, so there is a global assessment of the abdomen and pelvis. It is excellent for liver, pancreatic, renal, and bowel pathologies. There are three-dimensional reconstructions allow complex fracture imaging. The multiplanar reconstruction and three-dimensional imaging, example CT angiography and colonoscopy, and ability to guide interventions such as percutaneous biopsy and drainage. Okay, so this all are the findings on these are the strengths of the CT scan. So there are also few weaknesses. So it has a high radiation dose, so the poor soft tissue resolution of the peripheries and the superficial structures. The patients need to be able to lie flat and still, and it is less readily available than plain films and the ultrasound. Okay, so these are all the weaknesses of the CT scan. So we'll start discussing with the CT scan. So as we discussed on the chest X-ray, the diagnosis of the pulmonary contusion is very difficult on a chest X-ray because it is not evidently present at the time of admission, and it takes times to get evidently detectable on a chest X-ray. So that's why we usually get a CT done if we are suspecting a pulmonary contusion. So here you can see the arrow indicates the contused lung, which appears as higher density tissue because of air space hemorrhage and associated edema. So what happens is whenever so the air has the minimal Hounsfield unit. Okay, so the density is very low, but as the air filled spaces gets filled with hemorrhage and edema, that is the fluid, the density increases, and this leads to radio opacity, which appears as contusion. Okay, so that is the basis of detection of pulmonary contusion. So this is the image in which you can see there is a tubular structure in the right iliac fossa, and it is inflamed with the adjoining tissue edema, and again you can see we can clearly see this tubular structure is not associated with any lump formation or collection adjoining to it. So this is a classical feature of acute appendicitis on CT. So next, coming to the appendiceal abscess. So here you can see there is a collection which has been measured and present in the right iliac fossa, and there is also presence of contrast enhanced lining, which denotes there is lot of dilatation and hypervascularity of the appendix, which is classical with appendiceal abscess. So here you can see there is a gastric mass originating from the gastric body, which is kind of radio opaque, and it is taking up it is hypervascular, that is why taking up the contrast. So this is a classical of gastric cancer. The same you can see in a same section. If a patient is having GIST, it is not as contrast enhanced as adenocarcinoma of the stomach, and it appears as the protrusion from the fundus of the stomach, and it is not as hypervascular as the gastric cancer. The next important finding in a liver CT study is defining the three entities, that is the focal nodular hyperplasia, adenoma, and the hemangioma. So the focal nodular hyperplasia is hypervascular on arterial phase. You can see on the left hand side it is very hypervascular on the arterial phase and is isodense to liver on the venous phase. So in the FNH venous section you can see it is not very much delineated from the adjoining liver tissue. And the next finding it has, as you can see in the both section, that is the arterial and the venous of the FNH, is the presence of central scar. Okay, coming to the adenoma. Adenoma is hypovascular, and as you can see the adjoining liver tissue is illuminated with the contrast but not the adenoma. And the hemangioma is has a asymmetrical peripheral enhancement, that is classical of hemangioma. So again we can see the CT scan of, so as we discussed about the presence of extraluminal air in a patient of liver abscess. Here we can see the CT scan of a patient of amoebic liver abscess. So here you can see as we have marked from the black arrows, the lesion is peripherally located and round, and the rim is non-enhancing. You can see the black arrows, that is it shows the non-enhancing rim but shows peripheral edema. There is adjoining peripheral edema in the liver tissue, and there is extension into the intercostal space shown by the white arrow. So this is classical of amoebic liver abscess. Again you can see on a CT that the CT is showing air fluid levels with rim enhancement. Okay, so this is classical of pyogenic liver abscess, and you can also see a calcified head cyst in an adjacent liver lobe. Okay, so this is how you differentiate between three entities. That is, now you can again see an active head disease usually producing a non-calcified liver cyst, and cyst within the cyst, floating layers of germinal membrane can be seen. Okay, so this is classical of hyatid disease. So there are three infective pathologies related to liver, and this is the two types of liver abscesses, that is the pyogenic and the amoebic and the hyatid disease. So you need to be able to differentiate all these three entities on CT scan. Now considering the oncological CT scans you find in your exams, you saw the first point they ask is they don't ask for the pathology, they ask for the anatomy. Okay, so the problem is that most of you are not able to detect the anatomical structures on axial section of the CT. Okay, so here you can see we'll go one by one. So the one is marked as the portal vein. Okay, hope you are able to detect that one is portal vein. The 3 is the cystic duct and the gallbladder area. The 4 is the common hepatic duct, and the 5th is the bifurcation of the common hepatic artery into the gastroduodenal artery and the proper hepatic artery. Okay, so this is the 5th. The 6th is the dilated pancreatic duct, and the 7th is the splenic vein. Okay, so this all are the all structures are very important for the oncological clearance in a patient of carcinoma, head of pancreas, adenocarcinoma, or adenocarcinoma duodenum. So honestly, what they give you during exam is they give you image, and they just ask for the anatomical structures, and this you can, the eye for this you can develop by repeatedly going through various CT images you encounter in your daily clinical life. So again so that was a more cephalid section. Now coming to the more caudal section. So it is a contrast enhanced CT scan of a patient with carcinoma head of the pancreatic head, carcinoma of the pancreatic head. So the first thing you need to notice is the dilated bile duct. Okay, it is marked as 1. The next thing is the main pancreatic duct is also dilated, and the 3 is the superior mesenteric vein, which has a thrombus in it. Okay, so this all 3 structures are very important, which define whether you will be able to do proper resection or not. Okay, so the thing is that as we move down, then only we are able to see this structure like splenic vein on all those things. Okay, so you need to understand what from where this segment has been section has been taken. So in the previous image you were able to identify the cystic duct. So cystic duct is more cephalate than the gallbladder fundus. Okay, so here you can see the gallbladder fundus and not the cystic duct. Okay, so the 4 is marked as the distended gallbladder. Okay, so as we move down, we are able to identify the structures. So in that way you identify, you plan, and you discretely delineate all the structures you found out. So some of the trauma CT scans. So here this is a CT scan of pancreatic transection due to a bicycle handle injury, and you can see there is a complete transection of the pancreas, and a distal pancreatectomy was done for this patient. Okay, so this is a classical of pancreatic injury. So in the next image you can see this is also transaction injury. Here you can see the the white arrow has been marked along the neck, and there is a transfused non-perfused segment of pancreas with surrounding edema as identified with the arrow. Okay, so here also a distal pancreatectomy was done. So this is more proximal transaction than the previous one, and more amount of pancreas needed to be resected in this patient. Okay, so this is how pancreatic transaction or pancreatic injury looks like on CT scan. Then next, coming to the more common entities like pancreatitis. So here you can see that there is presence of acute necrotizing pancreatitis marked by X. So there is areas of reduced enhancement in the pancreas. There is peripancreatic edema and the stranding of the fatty tissues. These are all hallmark features of acute necrotizing pancreatitis. So what happens in your exam is that you get CT scans of very evident pathological findings. Okay, you don't get X-ray of dubious or equivocal findings on CT scan. Okay, so but those CT scans are of few of the commonly seen pathologies with their best characteristic features being seen on the CT scan. Those CT scan only are being asked in your exams. So this is a very classical feature of acute necrotizing pancreatitis. So again, if there is a infected pancreatic necrosis, we can see there is a reduced enhancement in the adjoining pancreas. There is peripancreatic fluid, but the most important finding is the collection of pockets of gas within it. Okay, marked by the white arrow. And in this patient you need to go ahead with the percutaneous drainage and antibiotic therapy. Okay, so the presence of the gas within the necrotic pancreatic tissue makes it as an infected pancreatic necrosis, and the management changes. Okay, so this is also a very classical CT scan image. The next is we'll be dealing with other pancreatic findings. So this here you can see on the left hand side we have marked the black arrow. We can see there is a dilatation of the pancreatic duct, and on the right hand side we can see there is a pancreatic calcification. So the black arrow shows on the both hand side the dilated pancreatic duct, and the white arrow shows the presence of calcification within the pancreas, which are classical of chronic pancreatitis. Again, we have a So this here we come with the most commonly seen finding in our emergency. We have seen lot of x-rays associated with intestinal obstruction. Now we'll be seeing few of the CTs also. Okay, so here you can see, as we discussed, the thinner arrows shows the colon. Okay, so colon is always on the periphery. Okay, so on the center we have the small bowel, so it is shown by the thicker arrows, and it shows that the small bowel is dilated, the large bowel is collapsed. So this means we are dealing with a small bowel obstruction. Again, this has become very evident nowadays, and the INI people have asked this twice in last 3 years, so you need to be very careful about these findings. So axial CECT image showing a retained swab as demonstrated by the radio opaque material. So the white line is showing the radio opaque line. There is lot of air foci within it, and this is classical of Gaussy pyboma. Okay, so you have a retained mop inside the patient abdomen, which looks like this on a CT scan. Okay, so you need to be very careful about this finding. Again, this for the hernia, they only ask this image, that is the Spigelian hernia. So in the first axial section, you can see there is a protrusion of the intestinal loop is shown by the arrowhead, and the arrow shows that it is covered by the external oblique epineuritis. Okay, so this is the classical finding of Spigelian hernia, and this makes it different from all the other types of ventral hernia. So in all other types of ventral hernia, the content won't be covered by the external oblique epineuritis, but here it is covered by the external oblique epineuritis. Okay, in the lower section also, the arrowhead shows the content, and the arrow shows the presence of external oblique epineuritis. So this is classical of Spigelian hernia. So now we have discussed radiological imaging, we have discussed X-ray, we have discussed barium images, we have discussed CT. Now we'll be going through ultrasound. So ultrasound, there are two principles. Okay, so the piezoelectric effect and the pulse echo principle. Okay, so the piezoelectric effect is nothing but the piezoelectric crystals are there which expand and contract to interconvert the electrical into mechanical energy. Okay, so this is known as the piezoelectric effect. Then we have the next principle, that is the pulse echo principle. And what happens here is, when ultrasound waves contact an organ, some are reflected, some are transmitted through the organ or tissue, and the reflected waves return to the transducer and generate electrical impulse that are converted to the image seen on the monitor. Okay, so this is how the ultrasound works. Okay. So coming to the various type of ultrasound waves. Okay, so when we use the frequency of the ultrasound while scanning can be adjusted. Okay, so that depends on the target organ which we are looking upon and the location of that organ. Okay, according to which the radiologist adjusts the frequency of the ultrasound waves. So if you have low frequency ultrasound waves, the wavelength becomes very high, and this leads to deeper penetration of the ultrasound waves, but it cannot detect finer structures, and this leads to lower resolution. Okay, so the next thing is, if you increase the frequency of the ultrasound waves, the wavelength becomes very low, and this leads to lower penetration because it gets reflected back, and the resolution but improves because it can detect finer structures. So this is the whole basis of adjusting the frequency of the ultrasound. So there are few terms which are associated with the ultrasound waves, ultrasound examination. So first you need to understand the concept of echogenicity. So you'll have your reports in which they will be mentioning these terms like anechoic, isoechoic, hypoechoic, hyperechoic. So this all depends upon the echogenicity of the structure which they are examining. So echogenicity is nothing but degree to which tissue echoes the ultrasonic waves. So what happens is the reflection in the ultrasound image is depicted as brightness. Okay, so if you have if you have large amount of echoes from a pathological structure, you will have lot of brightness in your ultrasound images. Okay, so the brightness depicts echo. Okay, this has been very clear. So the anechoic structure is nothing but there is no internal echoes and it appears dark or black. Okay, so if it is dark or black, it means the ultrasound waves are not getting reflected back and they are all getting transmitted forward. Okay, then becomes the isoechoic. If the structure is isoechoic, it means there is no different in the echogenicity of that pathology and the tissue in which that pathology is present. Okay, then comes the hypoechoic. So hypoechoic is less echoic or darker than the surrounding tissue. Okay, so the surrounding tissue will appear more brighter than the pathology you are examining, then you call it as hypoechoic. Then the hyperechoic is it is more echoic or brighter than the surrounding images, surrounding tissue. So here you can see the structure is anechoic. So the adjoining compared to the adjoining structures, there is no presence of any echo from the content within the structure, and there is presence of the posterior acoustic enhancement. So the wave is getting reflected by the posterior margin of the structure and the tissue in which it is present, which is causing the posterior acoustic enhancement. So this is a very classical radiological ultrasound image in a patient of gallstones. So here what we get is we get the clearly defined wall of the gallbladder. Then we get a very echoic structure, and this echoic structure imparts a shadow along its further path. Okay, so we call it as WES complex, that is wall echo shadow complex, which is classical of cholelithiasis. So here you can see it is appearing bright. Okay, so this is a hyper echoic structure compared to the surrounding structure. So coming to in our clinical finding or for our examination point of view, the only ultrasound images or examination questions you have been asked for so far are based on the FAST. Okay, so you need to be very thorough about FAST examination. So in FAST, first you put the ultrasound probe at the xiphoid process, and you look for any pericardial effusion. Okay, so at the xiphoid process, you can see the right ventricle, left ventricle, and the pericardium. Okay, so if you will have, this would be the normal appearance. So the left lobe of liver should be at the apex, and the below would be the right and the left ventricle, and the below this there will be pericardium, and there is no presence of water because there is no brighter structure seen within the two layers of the pericardium. But now here you can see there is lot of brightness enhanced between the two layers of the pericardium, and in such patient, if there is a presence of pericardial effusion, the linearity or depiction of the ventricles also decreases increases. So here in this image you are able to detect the two ventricles delineate the two ventricles very prominently, but here you can't see them. Okay, so this is classical of pericardial effusion. The next thing you do is look for the perihepatic window. Here you put the USG probe at the 12th rib along the mid axillary line, and you want to look for any free fluid between the liver and the kidney, that is the Morrison pouch. Okay, so here this is abnormal perihepatic view. Here you can see there is presence of liver, then there is a presence of kidney, and there is presence of white line between the two, and this denotes the presence of fluid which is providing echogenicity. Okay, the next view you want to look upon is the perisplenic window. Okay, in the perisplenic window you put the probe along the 10th rib in the posterior axillary line, and you look for the fluid between the kidney and the spleen. So here you can see there is no presence of fluid, and this is a normal finding. Okay, so coming to the last, in the last you put the probe 4 centimeter above the pubic symphysis and look for any fluid in the pouch of Douglas. Here you can see there is a free fluid in the pouch of Douglas, and this denotes that there is some hollow viscous or solid organ injury. So now we have moved from the fast to the E-fast. So in the E-fast, what we do is we put the ultrasound probe between the 4th and 5th rib in the mid axillary line, and we look for any presence of pneumothorax or air foci in the pleural space. Okay, so this is how usually the normal appearance is. So you have soft tissue, then you have the pleural line and the lung tissue. But if there is presence of pneumothorax, what we get is the stratosphere sign. So there is a similar kind of linings throughout because of the presence of the air foci, and due to presence of this air foci, the lung tissue becomes inapparent. Okay, so this is known as stratosphere sign, which is classical of pneumothorax on USG. So coming to the few of the common findings which they have been asking in your exam. So this is the acute cholecystitis. So as we discussed previously, in the cholelithiasis you get the wall echo shadow complex. So here you can see there is a wall echo shadow complex shown by the white arrow on the left hand side. The next thing you can see there is higher echogenicity by the gallbladder wall, which shows it is inflamed and it is thickened. Next thing you can see there is a pericholecystic collection, and this is also classical of acute cholecystitis. Now coming to the next important condition, that is the appendicitis. So here the first image you can see there is a long tubular structure which is present in the right iliac fossa, and you can see that there is presence of hyperechoic structures at the base and the tip of this long tubular structure, which are consistent with the appendicolith. And now on the transverse section you are able to detect the dilated appendix, and on the right hand side you can check the hypervascularity of the appendix by using the Doppler mode. So the next thing is the pyloric stenosis. So in the pyloric stenosis there is thickening of the circular muscles of the pylorus. So here you can see there is a lot of thickening on the left hand side, and again the pyloric channel has also increased in length, which leads to pyloric stenosis. So this is classical findings of pyloric stenosis on ultrasound. So what are the strength of the ultrasound? So there is no radiation, it is inexpensive, it allows interaction with the patient, it is superb, it has superb soft tissue resolution in the near field, it has dynamic studies can be performed, it is a first line investigation for hepatic, biliary and renal disease. The endocavity ultrasound for gynecological and prostate disorders, it can be used. Excellent resolution for breast, thyroid and testis imaging. It is good for soft tissue including tendons and ligaments. It is excellent for cysts and foreign bodies. The Doppler studies allow assessment of blood flow, and it is good real-time imaging to guide interventional biopsies and drainages. Okay, so this all are the strength of the ultrasound. Then coming to the weaknesses. So the interpretation is only possible during the examination. The visualization of the structures can be hampered by the overlying gas, bone and body habitus may also impact the scan. It has a long learning curve for some areas of expertise. The resolution dependent on the machine available, and the images cannot be reliably viewed away from the patient. Okay, so when you have the patient, then only you can have this images. So we have done with the ultrasound. Now we'll be moving towards the MRI. So MRI, what happens is so on the leftmost side we can see this is how the normally all our H+ ions are oriented throughout our body in different directions. Then we put this when we put the patient body in the MRI machine, there is a strong magnetic pole which orients all the H+ ions according to the magnetic field of the magnet present in the MRI machine. Okay, so after we are done with this, we give a radio frequency impulse of magnetic field, and how we look for how all this H+ ions return to their normal configuration which was present after the induction of magnetic field in the MRI. Okay, so depending on their return from the radio frequency impulse, we detect, we reconstruct the images, and we have the anatomy and the pathology. Okay, so this is the principle behind the MRI. So there is signal characteristics of tissue in response to different pulse sequences. Okay, so we can have either high MR signal or we can have low MR signal. The high MR signal would appear as white and the low MR signal would appear as black. Okay, so if the proton density in some area is high, okay, so if we have an inflammatory tissue, it will appear as white. Okay, it will appear as white. If we go for T1 images, since the T1 relaxation would be short, okay, if the T1 relaxation is short, then the images would be white, and if it is long, then the images would be black. Okay, so we'll see what appears white on T1 and what appears black on T1, but the basis of it is that if we have T1 relaxation short, then it produce high MR signal, and this will cause whitening of the images, and if the T1 relaxation is long, it will cause low MR signal and the black images would be produced. The next would be if the T2 relaxation is long, it would produce high MR signal leading to white images, and if it is short, it would produce low MR signal leading to black images. Now coming to the blood flow, if the blood flow is static or slow, it will produce high MR signal or white images, and if it is very fast, then it will produce low MR signal or black images. So here we have marked few of the structure in which you don't need to go into whether it's a T1 images or T2 images. So the best part of this is in most of the cases we don't need to differentiate whether it's a T1 image or the T2 image. Okay, so the air looks black on both T1 weighted image or the T2 image, T2 weighted image. The muscles look gray in both the T1 or T2 weighted images. Okay, the next thing we would be clearly describing how the structures look like. We discussed that liquids like CSF, urine, or bile appears. So we know what looks different on T1 and T2, similar on T1 and T2. Why now we need to go that what looks different. So liquids like CSF, urine, or bile looks dark gray or black on T1 and white on T2. Okay, so this is the thing you need to remember. Now you can see that the left hand image we have the ventricles are black, the intersulci or intergyri space is also black, and cisterns are also black. Okay, so this means it is a T1 weighted image because the CSF is appearing black. Okay, the next thing you need to understand that the white matters appears light gray on T1 and gray matter appears dark gray on T1. Okay, so the T1 images have the white matter as white and gray matter as gray. Okay, so this is the thing in the T1 images. So in the left hand side MRI scan we can see the CSF is black, the white matter is white, the gray matter is dark. So this is you need to remember, and this is a classical of T1 weighted images. Now coming on the right hand side, everything goes opposite. Now you can see the CSF in the subarachnoid space, ventricles, cisterns, everything it is white. So the white matter is appearing black and the gray matter is appearing light. Okay, so this is classical of T2 weighted images. Okay, so this is how you differentiate in the MRI brain whether the image is T1 weighted or T2 weighted. Now coming to the strengths of MRI. So there is no ionizing radiation. It is excellent for soft tissue contrast. It is the best imaging technique for intracranial lesions, spine, bone marrow, and joint lesions. Okay, so this is all classical of MRI. So what are the weaknesses? So weaknesses we will be discussing about the absolute and the relative contraindication. So if you have ocular metallic foreign body, cochlear implant, and cranial aneurysmal clip, you can't get a MRI done. If you have a pacemaker, first trimester of pregnancy, and claustrophobia, we need to assess the risk against the benefits, and then you can get the MRI done. Okay, so this all are the contraindications of the MRI. So we discussed about the CT, ultrasound, MRI, everything. Now we need to differentiate, and we need to make sure what would be the judicious use of this modalities. Okay, so we'll go from below. So we have already discussed about the contraindications. So the first thing you need to understand is imaging of the blood vessels. Okay, so blood vessel imaging is possible with CT but needs contrast medium. In ultrasound it can be done with the usage of Doppler mode, and in MRI it can be done, and it also does not require any contrast medium. Okay, so this all the three differentiating point between the three. Okay, so next thing you need to check for is the bone. So for the cortex, the CT is the best imaging modality, and for the medulla, the MRI is the best imaging modality. Okay, so this is the next thing you can understand. So now the third point you need to differentiate is the imaging plane. So in CT we have axial images, but coronal can also produce in some circumstances. Okay, so in ultrasound we have no imaging planes, and it can be variable at the time of a scan. in magnetic resonance imaging or MRI, the imaging plane is multiplanar. Okay, for the so as we move from the CT to MRI, the number of planes increases. Okay, so that is the thing. So now coming to the nuclear medicine, that is the radioisotope imaging. So the strength of radionuclide imaging is it allows functional imaging, allows imaging of the whole body. Bone scan has a high sensitivity for metastatic bone disease, fractures and infection. PET scanning is valuable in detection of metastatic cancer, and the weakness is specific agents are required for specific indications. Okay, and it is often non-specific and abnormal result may require further imaging, and generally poor spatial resolution. So this point of the spatial resolution we have tackled through combining CT with PET, but still the spatial resolution is not as good as in other modalities. So we have most commonly used radiopharmaceuticals and their localization mechanism and clinical application has been described. So iodine 123 and 131 is used for the thyroid function. Thallium 201 is used for the myocardial perfusion. Then the most commonly used radiopharmaceutical or the isotope is technetium 99. Okay, so we have lot of uses of the technetium. So technetium 99 phosphonate is used for osteoblastic activity detection, and it is used in bone scanning. Okay, that is the DEXA scanning. Okay, then we have technetium RBCs. So they are used to detect bleeding and blood pool imaging. Then we have technetium disophenin, which is also known as HIDA, and it detects hepatocyte uptake and biliary excretion, and this is used in hepatobiliary scan. Then we have technetium systemib, and it localizes by mitochondrial uptake, and it is used for parathyroid imaging. Then we have technetium DTPA, which assesses glomerular filtration and used for renal scan. Okay, so this all are the radiopharmaceuticals, their localization mechanism and clinical application. Now moving ahead with some of the MCQs. So which of the following statements are true? A low osmolality contrast medium are safer than their higher osmolality counterparts. Routine steroid prophylaxis is recommended before use of contrast in the high-risk patient. In the diabetic, metformin should be stopped before using contrast. The majority of the ionizing radiation comes from medical exposure investigations. Portable X-ray machines use much more radiation to achieve the same. Okay, so we have to find true statements. So there are multiple options correct. So the first statement is correct, that is the low osmolality contrast media are safer than their higher osmolality counterparts. So B statement is wrong because routine steroid prophylaxis is not recommended. C is also wrong because the metformin need not be stopped, but you need to be careful. And the majority of the ionizing radiation exposure come from the natural sources and not from the medical exposure from investigations. So this statement is also wrong, and the E statement is correct because the portable X-ray machine use much more radiation to achieve the same result. So the answer is A and E. So the following statements are true except, so we need to find the wrong statement. Okay, so the clinician referring the patient must balance the risk against benefit. Okay, this is a true statement. The clinician must give as much information as possible. Yes, this is also a true statement. Use portable machine or fluoroscopy wherever possible. This is a wrong statement. Take all precaution when using an image intensifier. This is also a true statement. And the lungs, heart and pancreas are especially vulnerable to irradiation. No, the thyroid, testes and ovary are the most vulnerable tissues. So the C and E are the wrong statement and the correct answer of this question. Okay, So this is a homework for you. So you need to diagnose this x-ray. So I won't be telling answer for this, you would be telling me on our WhatsApp group. So this you need to find the what are the radiological features and what is the most likely diagnosis. Okay, so this is the homework for you. So coming to the next question, which of the following statement are true? So we need to find the true statement. The higher the frequency of the ultrasound waves, the greater the resolution of the image. Okay, yes, this is a true statement. Ultrasound has no disadvantages, so this is a wrong statement. Ultrasound is useful for diagnosing occult pneumothorax. Yes, this is also a true statement. Change in the frequency of the ultrasound wave can be caused by red blood cells. This is also a true statement because this principle is used in Doppler imaging. So the answer would be ACD. Okay. So the next question is, 20-year-old female presents after a motor vehicle crash. She complains of diffuse abdominal pain. Her heart rate is 140 beats per minute and blood pressure is 78/42. FAST is positive. Which statement best describes the FAST examination? So a 3.5 megahertz convex array transducer should be used. This is the correct statement. The hepatorenal space known as Morrison pouch is viewed between the 11th and 12th rib in the mid-axillary line. Yes, this is the right statement. The splenorenal space is evaluated between the 9th and 11th rib in the left posterior axillary line. This is also a right statement. And the bladder should be preferentially be full before examination to allow for better visualization of fluid in the pelvis. This is also a true statement. So E is the right option because all the statements are true. So this is the this would be the last question, I believe. So a 75-year-old morbidly obese male presents after a motorcycle crash. The primary survey demonstrate an intact airway, diminished breath sound from the left chest, GCS of 10 and limited movement of upper extremities. Okay, his heart rate is 122 beats per minute, blood pressure is 80/44. A left chest tube is placed with a 1 liter of bloody output. The patient has 2 liter of saline infused. His heart rate decreases to 116 beats per minute and blood pressure is 86/48 mmHg. The FAST was indeterminate. What is the next best step to evaluate for intra-abdominal hemorrhage? Okay, so we'll go from downwards. So the exploratory laparotomy is not required because we have polytrauma and we don't know whether the patient is bleeding in the abdomen or elsewhere. Okay, and the FAST is indeterminate. Okay, so the exploratory laparotomy is out of question without we don't have any evidence. The next is D, exploratory laparoscopy. So whenever we have a patient with GCS of 10, we are suspecting some kind of traumatic brain injury. So the laparoscopy further increases the ICP and further increases chances of secondary brain injury. So we won't be doing exploratory laparoscopy in such patients. Then would be then coming to the C, that is the CT scan. So the patient is unstable. So unstable patient should not be shifted for investigation, and first should be what we can stabilize, then only such investigation can be done. Diagnostic peritoneal tap is the right answer because this can be done on the bedside and this does not require shifting the patient. If the diagnostic peritoneal tap cannot be done, then we can move ahead with the CT, otherwise not. Okay, so the serial abdominal examination is only done if the patient is vitally or hemodynamically stable. Okay, so with this I would be concluding my class. So the surgeon is the better radiologist. So you may find that why should we learning about all this imaging modalities, but it is very important because a surgeon is in a unique position to immediately compare radiology findings with the intracorporeal situation during surgery, what we often call as the clinical truth. Okay, Okay, so you will be better person to judge about the anatomical location and the pathological findings. So start getting into the habit of seeing the images. That's why that's how you'll develop an eye for all the radiological findings, be it x-ray, be it ultrasound, be it MRI, be it CT. So you need to go through the images instead of going through the reports. Okay, once you develop the eye for all these findings, you will find that it is very useful in your clinical findings, because most of the times radiologists are not in the best position to clinically correlate with the radiological findings and the current clinical situation of the patient. Okay, thank you, thanks a lot, you have been a great audience. So we'll be coming again, we'll be discussing some other topic. Okay, thank you so much.